السادة الحضور الكرام، السلام عليكم ورحمة الله. محاضرة اليوم عن أزمة كورونا والكوفيد 19 مع الممرضة سيندي من ولاية كاليفورنيا في أمريكا. So Cindy, thank you for joining us today here at the Continuing Education Center at Nينوى University. We are very happy to have you, and I'm sure you're going to give us some information about your expertise, your experience with the pandemic and COVID-19. So, Cindy, the virtual stage is all yours. We don't have like a stage here. It's all virtual because due to pandemic. So we can hear you over Zoom. So go ahead,
good,
Cindy.
Good.
Thanks.
Thank you. And thank you everybody for attending. My name is Cynthia Hughes. I've been a nurse for 20 years. My specialty is the emergency department. Prior to nursing, I was a firefighter, EMT. For 6 years in the field. I worked as a firefighter. I went to school, got my nursing degree. I have an associate's degree, and I am currently working on my bachelor's. I'm a couple classes away from completing that. So we'll just go into this. My credentials up there that are on the screen, of course, there's registered nurse, and then my degree, ASN. The TNCC is a trauma nurse certification. So I'm certified to handle trauma patients. My ACLS is acute cardiac life support. So that's basically, working codes. And then EMPC is certified. It's an emergency nurse pediatric certification. And some of these are the qualifications that we have to have to work in the emergency department. Okay, how do I do this? Hold on, guys. So you all know about the virus. It's become problematic across the United States and globally. Hospitals have been unprepared for this. It attacks the respiratory system, and it is spread throughout the world, where scientists are they're working really hard and diligently to to gain enough knowledge to avoid further infection. So they're working hard to find vaccine. They're working hard with they're sampling all the medications that will respond to it. And the biggest challenge right now in our country is keeping our patients safe. We have issues with people not staying home, spreading the virus. So the first case of COVID was reported in December of 2019, just a short history of it. And by March 2020, the World Health Organization declared it a pandemic. And so in just 3 short months, the infection was spread globally, and hospitals were not prepared. With limited space for these patients, the influx of hospitals, and not knowing the virus, whether it was droplet or precaution, hospitals were taxed with where to put these patients, how to handle the flow coming in. So everybody started brainstorming. And one of the things that we lacked was personal protective equipment. So I will tell you that with the question of whether it was airborne or droplet precautions, and not knowing, initially, our managers would not allow us to wear masks. We could wear a mask in a patient's room, a simple mask. We were not allowed to wear them in the hallways because they didn't want us frightening the patients. So there was like this big scare. And so I was pretty adamant that I wanted an N95. And I wore one. Because by law, they're supposed to supply you with the proper PPE, but we had a shortage. So it was frightening to go to work. And finally, recently, I think about a month ago, they pressed for statement that it was no longer just contact or droplet precautions. They are actually calling it airborne, calling for airborne precautions now. The N95 is something that we use to protect us, and there's so many different brands throughout the world. And the N95 is actually intended for one-time use. You put it on, you walk into a patient's room, you take care of that patient, and you discard it as you leave. That's what they were intended for. Unfortunately, because we've had such a shortage, we are having to recycle these, meaning we just use them daily. And some people have worn the same mask for a week at a time until they just start falling apart. This was the mask that they initially gave us, a simple mask. I guess, at that point it was like any protection is the best protection. Anything that we can put over our face. I wasn't agreeing with this. I demanded an N95. Now people are wearing, that's me on the left. We wear double masks. We wear the N95 and then a simple mask to protect it. And if we come in contact with COVID patients, we can discard the simple mask because they're a lot cheaper to replace than the N95s. And then on the right is a respirator for people that usually have, like, we give those, we're limited on those, but we give those to people that nurses that or staff, medical staff that have comorbidities that are higher risk, just to keep them safe. So when we first started, as I said, they were really tight with our masks, and they would only limit us to one, and for the entire shift. And so you held on to it, you cherished it. And I started stocking them and rotating them a week apart just to keep them safe. Nurses started protesting because we weren't having the proper PPE. They protesting, and some of them actually went on strike because nurses were getting sick. And on a personal note, I've lost 6 colleagues through this over the course of COVID. So yeah, nurses are going on strike. This is the technique I talked about, double masking. We're just doing added protection to keep ourselves safe. The CDC, this is just a thing I got from their website about a proper PPE, what's acceptable when you're taking care of these patients. We wear face shields, goggles, we'll gown up. Transporting patients, throughout the hospital, we wear full-on gear because we're behind the gurney as we're pushing these patients through the hospital. One of the things, this is actually taken, I took these pictures out of the facility that I am at now. They are asking nurses to throw their used masks into these recycle bins to take them and have them treated. I don't agree with this. I don't agree with having to recycle these. We don't know what kind of recycling process they're going through. They ask that you write your names on them and they'll return them to you. I'd rather just get a new mask. So hospitals started vamping up with COVID units. ERs were setting aside separate places to put these patients. Anybody coming in with fevers, respiratory cough, sore throat, chills, were getting set separately. We started setting up tents outside the hospitals to triage these patients. Some tents kept them out there, the minor ones, and sent them home if they didn't need to be hospitalized, if they weren't that critical, and were told to come back if they got critical. So this was keeping them out of our general emergency department. However, with weather changing and summer hit and the high temperatures, we had to start thinking about something different, because you can't keep these tents very cool when it's 100 degrees outside. This is the tent that is currently at the facility that I'm at in California. It's not as fancy as the previous ones. It's been used on occasion. Right now we don't have as many COVID patients coming in, but we're keeping it up because we're preparing for our third surge. So with most hospitals, there's not a lot of isolation rooms, or negative pressure rooms, I should say, where the air keeps the droplets and airborne stuff from going out into the general population. So they have started revamping the duct system, the air systems and stuff in a lot of areas to get the air circulating in the right direction so it doesn't go out to the general population in the facility. This is just another emergency department that set up a wing for their COVID patients. I worked at a hospital in Southern California that had two separate ERs, a pediatric ER and an emergency department. And they were connected by a door, a big double door. And so after it got hot, we took down the tent and we started triaging all of our COVID patients to the pediatric ER and then bringing our pediatric patients to the main ER. They had two separate waiting rooms. So we were able to keep them away from each other to some degree. And if we had to admit a COVID patient, we would take them outside and bring them in through a back door instead of taking them through the emergency department where they could possibly infect any people. We had a process of doing that where somebody would push the gurney and then some in full gear. And then we had a person that would go through in front of us with donning gloves and mask only and opening doors so we can get the patient through. Hospitals now are not allowing visitors. That's been some of the biggest challenge with family members. It's challenging because people get angry and you end up spending a lot of your time arguing with people because they can't be with their loved ones. And I understand that. I do. However, there's always liabilities, of course. But to keep the spread of the infection down, we're just not allowing people to come in. The only people that are hospitals that so far that I've worked at during this pandemic that are allowed to come into the facility with their loved ones are, of course, one parent for a child. And then if we have a pregnant person, she's in active labor, she is screened first. If she's actually going into labor, then we screen the husband and allow him to join her upstairs. I'm a traveling nurse. I have been a traveling nurse since 2013. And
شبعتوا؟ تعال.
Hello.
Sorry, Cindy. Someone is unmuted.
That's okay. So I have been a traveling nurse since 2013. And what a traveling nurse is I do assignments. I kind of have the luxury of, I have an agency that I work with, and I kind of have the luxury of saying where I want to go. And so I like California. California pays their nurses well out here. So I've been bouncing up and down the state, and I've gone to Florida, and I've gone to the East Coast, Massachusetts. So what a traveling nurse does is they go and they'll do an assignment for 13 weeks. Sometimes they'll extend, but they help out hospitals that don't have enough staff. And right now with the pandemic going on, traveling nurses are getting hired, and they're in high demand right now. So that's why I'm at where I'm at, because they need us. When I went through orientation for this job, there were 12 12 nurses just for the emergency department alone coming in because they're so short-staffed. Before going into the hospital, we get screened. They have us go, they ask us the questions, you know, fever, chills, body aches, any cough. They take our temperatures, and if we're over 100.1, we are turned away and told to go get tested. I've only had to do that once and had to stay home from work until my results came back. Why I was running a fever, I don't know. But I didn't have COVID. So one of the things that we've had problems with here in America is, in the United States, is people not following the social distancing. And right now we have elections coming up, and I'm sure you guys have heard the crazy news here, the stuff that's going on. A lot of people are not taking this pandemic seriously. And I have spoke with people just in general that think that as soon as the election is finished, that the COVID's going to disappear. And I just say, come work with me, come follow me at work, because it is a serious pandemic, and it's not a political pandemic, well, as much as the media is turning it into it. But we still have issues with people not wearing masks, and a lot of places are not allowing them into their businesses now without one. You can go to a restaurant and you can put on a mask and to get into their restaurant, and then as soon as you sit down, you can take it off. It just doesn't make sense. So there's a lot of takeout going on. But yeah, so social distancing, keep, you know, people 6 feet apart, and that's been a challenge. It's been a huge challenge over here. Of course, you know, we're trying to educate our public on diligent hand washing and using alcohol-based hand sanitizers, which there was a huge shortage initially, but somehow or another, we're that number is coming back up, and we're able to get more hand sanitizers. So yeah, and that's, you know, wear a mask if you go out. Trying to think if I have anything else to say. Does anybody have any questions for me?
So Cindy, thank you. You reflected the American experience from a nurse point of view. So our attendants, if you have any question to Sydney, please raise your hand so we can see you. Okay, Dr. Nazar, go ahead. Could you please unmute yourself, Dr. Nazar? يوجد علامة إزالة الكتم or unmute.
Hello. Hello.
Okay, we just heard you and then cut out. So.
Okay.
Right.
No, I cannot unmute myself. He told me you cannot. Thank you very much for your nice lecture and talk and about your experience there with COVID-19 in the USA. I would like to ask Cindy about her experience. Which way better to protect ourselves as a healthcare worker and a provider? Now we use double mask, we use face shield, goggles in the eye, but most of these it makes our work uncomfortable. From her experience there, is the use of double mask or triple mask with the face shield is necessary? And thank you.
Do I feel it's necessary?
Yeah.
Is that your question? Do I feel it's necessary?
Your own experience and the team there and the work there.
Yes, Absolutely. As I said, I've lost some coworkers, some colleagues. I've lost 6 of them that I've worked with throughout my traveling experience this year, or not this. Well, in the last, since I've been traveling since 2013, colleagues that I've come across during my traveling, I've lost this year. We still have nurses that will just wear simple masks throughout the ER. It's mandatory that we do wear them. But I have to tell you, I'm diligent about wearing an N95, and I'll double up with a simple mask over it. I haven't gotten it, and I think it's the best precaution. And eye protection, absolutely. I wear glasses, and they're just reading glasses, so I have a hard time wearing a shield or goggles, because when you're taking care of a patient, you have to take the glasses on and off. I mean, it's difficult, but you know, as I was telling Ahmed, you know, I was taking care of a patient the other day who just was sneezing, and I'm just keeping my fingers and toes crossed right now that I don't catch that, because I was right there in the midst of all of her. I mean, I was 3 feet away from her, not even that. So yeah, I think it's a necessity. I think we need to keep wearing them. Did that answer your question?
Yes, I think so, Cindy, because we don't have a raised hand. So Cindy, you talked at the beginning of your talk about you were not allowed to wear a mask. Is that correct?
In the beginning,
Yeah.
we were.
When was that?
The first, I'm going to say it was probably March, before it was March. Before it became a pandemic. We were allowed to wear a mask in the patient's room if we suspected that there was something respiratory, a respiratory issue with them, or a fever. And they only gave us the simple masks during that time, but we were not allowed to wear those masks throughout the hallway, throughout the nurse's station, or throughout the hospital. And that only lasted a week. And then the next thing you know, management is running around in N95s on, and the docs. I was watching them mostly because every single one of them wore N95s every day throughout their entire shift. So I just kind of followed suit, because they are going to know more than I do.
Okay, thanks, Sydney. We have a couple more questions. So Dr. Jafar, sure. Please go ahead.
Okay, thank you very much. Yeah, it's very nice lecture, and thank you again, Sandy, for being here and giving us such great information about your experience. I am wonderful about the people's, you know, the shortage of spaces in hospitals, and not all the peoples can really get inside the hospitals and getting the full services, medical services. So what I ask here, according to your experience, what you advise the peoples who they have already got the COVID-19, affected by COVID-19, I want to keep themselves inside their homes. So what you are advised, how they can deal with their families, kids, and how they can deal with their daily activities. So if, according to your experience, if you can give us some very precious advices, it will be very appreciated. And thanks a lot.
Right. Oh, thank you. So what if we have a patient that ends up with COVID-19, and I think that's one of the things too that we've been trying to educate the public with. If you have symptoms, don't go to the ER unless you are like severe. A lot of people were initially, and that's understandable. But they were showing up with just a minor cough and a fever. And it really wasted resources. So that was the struggle, was getting them to stay home and wait, see how it does, give it a few days. If you have difficulty breathing, and then please come, you know. But a lot of people are just surviving and staying home. My daughter got it early on. She is a nursing student. She's 27. And she just stayed home. She had roommates that she lives with, and she just stayed in her room, and they brought her food. They used extra precautions. They sanitized. They wiped down counters. You wipe down doorknobs. If the family has a separate bathroom for the COVID patient to use, leave that bathroom for that patient. If not, then everybody needs to, the patient that has to use the bathroom needs to, if they have the energy to. So use some wipes to clean any surfaces they may have contact with. It is difficult when a family member does get it, and you've got an entire household of people. The best thing to do is just isolate them in a room, like I said, and keep surfaces clean. I've even suggested putting a fan in the window to blow the air out, to kind of give it that negative pressure kind of thing. So the air is flowing out of the room, out into the air outside versus flowing out into a living area.
Okay, thanks, Cindy. We have a question from Mr. Akram. Mr. Akram, go ahead, please.
Hello, Cynthia. Thank you so much for taking the time to share your experience to the other side of the world. Actually, we are in Ninive University. We really appreciate it.
Thank you.
I was I'm pretty sure that you have dealt with so many COVID patients and with different age demographics. And as all know, we all have parents, a grandpa that we really care about and worry about. That at some point we might have the virus, like they contract the virus, or we be the reason for them to get infected. So I was wondering if you would be able to share with us your experience with dealing with elderly patients, like the timeline they take, like from getting infected to be fully recovered, and also another aspect of COVID is like we hear that there are patients who get infected twice.
Yeah, we are starting.
I'm really curious to hear from you, if you can also like share with us your experiences in regard of like having patients who get the COVID twice. And thank you so much.
You're welcome. Thank you. So that is actually just now starting to occur. I have not specifically had a patient that is on its second course. But with the elderly, you know, this virus is so unique that what we're seeing is people, it's very unpredictable. For example, I had a 94-year-old woman who was COVID positive. She was running a fever, and that was her only symptom. She was not oxygen dependent. She didn't have a cough, but she was positive. We kept her because of her age. We admitted her just to make sure she didn't decline. She was released 4 days later to go home. In the room next door, I had a 64-year-old patient. And mind you, the 94-year-old, the only medication she was dependent on was for blood pressure. I had a 64-year-old she was in her 60s, next door, who was only also on high blood pressure medication. That was her comorbidity. And she struggled. We ended up putting her on a BiPAP just to get air into her because she couldn't hardly breathe. Her respiratory rate was in the 40s and 50s, just struggling for air. And if she was off oxygen, she was dumping down to 60%. So with the BiPAP, it brought her back up and she was able to actually get some sleep. So you have, you know, a 90-some-odd-year-old and a 60-some-odd-year-old with the same medical history as far as medications that they are on, and they handle it very differently, you know. And initially when this came out, we were careful with our elderly because we figured it would inflict them the worst. And it has in a lot of areas. Nursing homes have been, you know, overcome with it and had to go into quarantine. But I've also lost some young, healthy people. A 32-year-old, no comorbidities. It just took him down. He tried to stay home. He tried to stay home for probably almost 2 weeks. And by the time he got to us, we couldn't save him. Then there's the pediatric patients. And I think one of the struggles too that we're having is our tests. I don't think they're very reliable. I had a 3-year-old boy come in, transferred from another facility to ours because we could handle him on our unit. They didn't have it set up for peds over at their facility, so they sent him to ours. But they said he was negative. They tested him over there. They did a rapid screen on him, and it came back negative. Well, the kid presents to me. His respiratory rate is in the 70s. His oxygen without his cannula on, and I think I had him on 3 or 4 liters, was in the low 90s. And he was just lifeless. When you got a kid that doesn't move, doesn't fight you, doesn't scream or cry, you know he's sick. So I asked the pediatrician, I said, you know, I know they tested him and he was negative, but I really think that we need to check him again. So we did a rapid on him and it came back positive. So, you know, it's this virus is so unpredictable on how it affects people. So that's the thing that I have seen the most. And it's unique that it's not the same. There's like no written guideline that this is exactly how you're going to have, or this is the sickness you're going to get, and this is how you're going to get it, or how you're going to feel while you're having it, because it's so different with everybody. And then, you know, of course, getting proper testing, whether the kid was tested appropriately or a faulty test, we don't know. But as far as age goes, it doesn't seem to. The elderly, yes, they will get it worse, and we've probably lost more elderly than we've lost anybody else. But it's a unique virus. Did that answer the question?
Yes, Cynthia, I think so. Dr. Ahmed, go ahead, please.
Hi, Cindy. Thank you so much for the valuable information that you presented. I don't actually have a question. I just wanted to thank you so much for accepting our invitation to present a talk about this very interesting and exciting topic. And I hope we will have more future collaboration with another topic. So thank you so much.
You're very welcome. Thank you.
So Cindy, I got like one last question. The question is, what is the lowest SpO2 percentage that you encountered in the past couple of months, and he or she then recovered fully?
So being an emergency department nurse and the amount of COVID patients that have gone through that I've processed, I don't always get to follow their cases. So once they leave our department, I just kind of have to watch the news and see what our numbers are, or talk to management to see who survived and who didn't. I don't always get to follow them. But was that the answer you were looking
Yeah,
for?
we had like stories about someone who have like 60% O2 and then he recovers fully. So something
As far as-
amazing.
Yeah, the lowest I've probably seen is probably in the 50s. And those
Okay.
are the patients that aren't surviving. There's, you know, initially we are intubating. It seems like we've initially started intubating everybody, and they're now finding that that's not always the best case. But because I think statistically, and don't quote me on this, but I think most of the patients that get to the point where they're intubated probably don't come out of it as much.
Okay, I think that's wraps up our session. So we don't have any more questions. So thanks again for your time. And
Thank you.
I'm hoping we can like share our experience, because we're here in Iraq, we have very experienced doctor, whether they are ANT or pulmonologist. So can you arrange something for a doctor from Ninive University to present his or her experience to you guys in USA? So if you can do that, please coordinate with Dr. Ahmed about it.
Yeah, absolutely.
All right, thank you.
Thank you.
All right, goodbye. Have a nice day.
You too.
سادة الحضور، ننهي فعاليات هذه المحاضرة. شكرا جزيلا للاستماع.